Palliative care and multimorbidity, learning from trajectories of decline to trigger a 4-stage cycle. Most people in economically developed countries now follow one of 3 illness trajectories towards the end of life. Acute decline, typically progressive cancer; intermittent decline, typically heart failure or COPD, or a gradual decline from a lowish baseline, typically in old age or dementia. However, older people with multiple conditions may have dips in their gradual physical trajectory due to accidents, pneumonia, or hospital admissions. But apart from the progressive stepwise physical decline, people have predictable psychological, social, and existential needs. Dying is indeed 4-dimensional. So in older people, how might the psychological trajectory progress? There may be anxiety or depression associated with a physical dip, or worry about getting dementia or being admitted to a care home. Social concerns may include not seeing friends, especially when acutely unwell, or not getting out, or feeling they are a burden to their relatives. Existentially, well-being may suffer if someone is unable to do what they are used to do, and a feeling of loss of control may make sometimes people lose their sense of meaning and purpose of life, causing agitation and distress. So to adopt an individualized approach to people with multimorbidity and palliative care needs, we propose a 4-stage care cycle. 1. Early identification. 2. Multidimensional assessment. 3. Care planning. And 4. Communication with all settings and people involved. So understanding these frequent concerns and likely patterns allows us to identify early by proactive screening when a patient may benefit from more comprehensive care. This allows us to detect people with early palliative care needs during the so-called first transition and start advanced care planning process early before reaching the second transition of imminently dying. Then we must do an individual assessment to firstly check in what dimensions there may be problems or difficulties, and to perform a situational diagnosis, that is, at what stage of the trajectory is the person, A, B, C, D, E or F. Then it's time to anticipate the patient's concerns about how the illness may progress and help the patient, clinician and family plan together, often in the face of great uncertainty, to meet the patient's and carers' wishes. Then we must communicate a care summary to everyone the patient or carer may contact in an emergency, ideally electronically, updated as plans progress. This 4-stage cycle is an essential part of personalising care regardless of whatever tools are used by primary care, palliative care or geriatric teams. To identify palliative care needs, some clinicians find the surprise question, that is this patient sick enough to die, useful? Or specific tools to help trigger this. Assessment can be aided by various primary care, palliative care or geriatric tools also. Planning can use a number of tested formats or names that should be acceptable to patients to receive an extra layer of care. And communication, a system to routinely electronically share updates in the care plan across all settings, is very valuable. So the take-home message is that as health declines in multimorbid patients, a 4-stage cycle of enhanced integrated care should be triggered and repeated. We can do this both in the community and in hospitals, and must avoid separate silos of care. If patients have discussions and planning based on their likely multidimensional illness trajectory, their quality of life and dying will improve. This can reduce distress while promoting a realistic understanding of normal aging.